Hello, my name is Mathieu Jabaudon. I am a French anesthesiologist and intensivist from Clermont-Ferrand, France. And I will talk today about INT'L ICU sedation. I want to thank the Lebanese Society of Anesthesiology and the organizing committee for inviting me to this very nice conference. I'm a bit sad that I could not make it to be with you in Beirut today. Really hope there will be future opportunities for me to visit your beautiful country. At least I have this picture from your beautiful city here behind me. So these are my disclosures, and it was also a good opportunity to show you a view from the region I live in here in Auvergne in France. And today, before we talk about inhaled anesthetics as a sedation strategy in the ICU, I just wanted to emphasize that sedation itself is not a goal. And as you can see, we are not talking only about sedation. We are talking about a bundle of measures that have all proven efficacy to liberate patients more rapidly from the ventilator, from the ICU, and limiting by this way the long-term consequences of ICU stays. And so as you can see, the choice of sedation drugs, for example, is only a part of the C feature of the A2F bundle. And of course, we should interrupt sedation whenever possible. We should try to awake our patients more regularly, more rapidly, and make them breathe spontaneously also more rapidly whenever their clinical conditions can allow us to do so. And keep also in mind that it's always better for the patient to adapt the ventilator to the patient's needs and not only the patient to the ventilator. And in this way, you could add a R for respiratory drive control to this bundle if you want to have a broader view of the approach we should promote actually in our ICU patients. So with this in mind, we will be talking today about volatile anesthetics for ICU sedation. And even though things have started a long time ago with chloroform, ether, and then allotane back to the 20th century, the modern halogenated agents we're talking about are mainly isoflurane, sevoflurane, and a little bit less of desflurane, given its higher price, given its higher ecological impact. This is something we can discuss if you want after the talk. So these agents actually have a unique pharmacological profile with very short and stable context-sensitive half-lives, which is really different from any other drugs that are available by the intravenous route. And so this can help to titrate better, to have shorter onset and offset of action in our patients, which could be useful also in ICU patients, in addition to patients in the OR. Inhaled sedation is also mainly exhaled sedation in the way that the lungs are the primary route of elimination of the agents. And this is in parallel to a minimal metabolism rate by the liver of these agents. You can see the details here on the right of the slide. And so very minimal metabolism, some metabolites that are mainly driven by the fluoride ions, which are mostly inactive in humans, or there's at least no evidence available to date that they may have direct effects in patients. What's interesting also with inhaled anesthetics is the access to the expired fraction monitoring. This is true in the OR during anesthesia, and we will see later in the settings that we can use in ICU patients. You will also have access to the expired fractions. So we know from anesthesia studies that this is a good surrogate marker of the cerebral concentration of the agent. And with some colleagues, we could show in this study that these expired fractions here, for example, for sevoflurane, are quite well associated with the clinical scores we're using to monitor and titrate sedation needs in our ICU patients, meaning that it can be an additional helpful tool to use to titrate your sedation, and meaning also that the effects of inhaled anesthetics are very predictable indeed in these patients. There are also evidence in the literature to support that using inhaled anesthetics in ICU patients will reduce the times to awakening and to extubation compared to intravenous sedation. It has been nicely showed in a very small randomized controlled trial from a French team in Montpellier, from Dr. Jabaudon's team. And it has been also confirmed by meta-analysis published in the recent years. There's also growing interest, and mainly research interest, in some potential specific organ protective effects of inhaled anesthetics, which could be relevant to ICU patients. First, inhaled anesthetics may be associated with shorter times to follow verbal commands to awakening. They could be also in some small studies associated with fewer delusions, hallucinations. And there's currently an ongoing trial, multi-center randomized controlled trial here in France from the team in Brest that is specifically evaluating the effect of inhaled isoflurane compared to intravenous propofol on the incidence of ICU delirium. There's also an ongoing research going on looking at the potential lung protective effects of inhaled anesthetics. There are multiple preclinical studies showing actually improved oxygenation, decreased alveolar edema, and decreased lung and systemic inflammation in models of acute respiratory distress syndromes. We don't know yet all the mechanisms of action of these potential effects, but this is something that has supported a first clinical pilot study a few years ago from our team, and right now multiple, or at least these two large randomized controlled trials that are ongoing in Canada, the SAVE ICU trial, and in our team in Clermont-Ferrand, we are also investigating through the CESAR trial the effect of sevoflurane in patients with moderate to severe ARDS. The recruitment has just finished, and we are now monitoring the database before data are available for analysis. So I hope we'll have those results in the next year. There's been, just to finish on this topic of acute lung injury, ARDS, there's been this review, this expert review paper published at the end of year 2020 on how to provide analgesia and sedation in patients with ARDS specifically, which is also applicable to other settings, of course. And beyond the analgesia first strategy that we should aim with minimal sedation whenever possible, one of the elements that was provided by this expert paper was that you could consider using a volatile anesthetic for sedation of ARDS patients, whatever the need for sedation, the sedation target, from mild to moderate to deep sedation targets. So that's an important thing to keep in mind, that it's already done in most centers, and potentially you can consider it without major problem. So how can you provide inhaled sedation in the ICU patients, and not as it was done with ether, as you can see on the picture on the up left, or in the OR using big anesthesia machines and vaporizers? Actually, there are actually two systems that have been available for a few years now in some countries that can be placed directly in the on the circuit, the respiratory circuit, in parallel to standard ICU ventilators. So this was a technical improvement to deliver sedation, ICU, inert sedation in the ICU, and these are basically two devices which are vaporizers that you will place between the Y tube and the endotracheal tube. So where you would usually place your HME filters. Um, I won't go into details in differences between both systems, the Sedaconda ACD or the Mirus. There's only the Mirus that can deliver desflurane in addition to ISO or SIVO. Both devices also act as HME filters. Basically, they have good or excellent, let's say, bacterial and viral filtration properties. They are also heat and moisture exchangers. So the message here is that you want to use additional HME filters or active humidification devices if you use these devices, Sedaconda or Mirus. What you should know is that these devices have, of course, additional dead space volumes. There's a miniaturized version now of the Sedaconda ACD with a 50 mil dead space volume compared to the 100 mil dead space volumes of the larger Sedaconda ACD or of the Mirus. This is a bit higher than most HME filters, but not that much if you consider the larger ones. But you will still need to take this in consideration and check, of course, that the patient has sufficient time to exhale. Check your IE ratios, the existence of autopleep and things like this if you're managing patients with more severe lung injury, for example. So these systems also are also connected to a gas monitor, which is, as I said earlier, quite useful because you will have access to the expired fraction mainly, which will help you probably titrate the needs of sedation, especially in situations where the clinical scores, such as the RAS, are unavailable. I'm thinking about patients under paralysis, for example, and this could maybe help not to overdose the sedation drug. This is speculative because there's no specific study on this subject, but this is something that is quite useful on a daily basis. You also access to CO2 monitoring, continuous CO2 monitoring, if you wish. So here also it could be interesting. These gas analyzers, this is one model, but there are others, or they could be combined in the Mirus directly. They have a water trap. There's also an antimicrobial filter here in this water trap. You would sometimes need, of course, to empty this water trap if it's full. And keep in mind that you have a gas outlet from the analyzer that you also need to scavenge at the end. The devices, both the Sedaconda and the Mirus, are both carbon reflectors inside their structure. This means that a good proportion of the agent will be kept during expiration in the filter, and it will be delivered during the next inspiratory cycle, which is quite useful to reduce the needs in the total volumes of the sedation drugs, because you are, let's say, recycling what was not used previously. It's said that up to 90% of these agents can be recycled by these carbon reflectors, meaning that you will have to take care of the 10-20% remaining. And as you remember, there's also this gas outlet from the gas monitor that you would need also to consider. And for this, the systems that are available for inhaled ICU sedation include either a scavenger, on the left, the fluoroabsorb scavenger, which you will change regularly depending on the consumption of the agent, or you could, on the Mirus, also use another system which dilutes basically the agent, and the agent is then released in the atmosphere through the hospital system. Looking at this exposure, this atmospheric exposure of the agent, which is, of course, a modern, a current concern for our practices, the ecological concerns, you will, of course, be able to measure a little proportion of agent in the atmosphere. If the system is well used, actually, and if you replace each element whenever the manufacturer recommends it, you will have really very, very minimal exposure, which are far below, of course, the recommended exposure limits in most countries of the world. Still, this has to be, in my opinion at least, be put in parallel to also the ecological concerns that we could have when using intravenous sedation. It's not direct carbon emission of the agents in this case, but there's also an ecological impact, and the comparisons between both are currently lacking. We know that all inhaled anesthetics are not the same in terms of CO2 equivalence, and there's clearly here a better signal for sevoflurane, isoflurane over nitric oxide or desflurane, which are abandoned actually in these times in some countries, even in the OR. So my preference, of course, would go to ISO or SEVO. Some questions arise on potential serological effects on pregnant women, effects on their fetuses, babies. There are actually animal studies showing that very high dose exposure, 4,000, 6,000 particles per million, could be is associated in animals with congenital malformations, fetal development, abnormalities, etc. If you look clearly at what could be the maximal exposure, even if we don't use the system correctly in the ICU setting, the levels are far lower than the levels that were associated with this fetal or pregnancy complications, meaning that there's no clear clinical evidence that this could be a problem in pregnant women. Actually, some pregnant women receive inhaled anesthetics in the OR whenever it's necessary during their pregnancy. But of course, we should be careful in pregnant women or women wishing to be pregnant. All studies available today support that inhaled anesthetics have no effects on renal and liver laboratory markers, meaning that they are not associated with acute kidney injury or acute liver injury or even chronic injuries. Of course, there could be an accumulation of the metabolites, fluoride metabolites, as I mentioned earlier, but this has never translated in organ failure or changes in laboratory markers. Something we should keep in mind if we use inhaled anesthetics, but this is true also in the OR setting, is this very rare risk of malignant hyperthermia, but it's very spectacular. It can be associated with mortality in less than 5%, but it's still a lot, and it requires urgent recognition and urgent treatments. We know that there are some at-risk profiles, medical history of MH or muscle disease disorders. The incidence is very low, but we should be aware and should be able to recognize these symptoms, which are not so specific, but the presentation should be suspected in at-risk patients or any patients when it occurs. There's an antidote, dantrolene, which is, of course, an asset. In conclusion, INT'L ICU sedation could be a very interesting alternative when sedation is needed, and if sedation is needed, it provides and it's compatible with lighter to deeper sedation needs. And it's very compatible with this A2F bundle I mentioned at the beginning of my talk, because it has ideal or quasi-ideal pharmacological properties with short onset of actions, no impact on liver renal failure, and very good profile for titrating better the needs of our patients. It requires, of course, multidisciplinary training, but it's safe and easy to use. And there may be potential organ protective effects that are under investigation and that could be further advantageous. Thank you.